Hi.
Rima when you want.
Hello, everybody. Good morning, good evening, wherever you are. This is the Congenital Heart Academy, the Fetal Series, and the collaboration with the Fetal Gulf Heart Group. And today we're very honored to have also the Fetal Heart Society collaboration with us. And we are going to talk about a very important topic, which is the guidelines and the screening. And then we have also the panelists and the discussion. And the idea of the webinar is to open the eyes and the ears for the value of the fetal echocardiography guidelines and the value of screening, putting in mind that the detection rate worldwide of congenital hearts in utero is still not optimal. Some countries are better than others, but why? We try to somehow find a way with the guidelines to implement better screening and better echo. Today, our first speaker is a very well-known figure, and it's Dr. Mark Kalinsky. And Mark, can you please introduce yourself? You just moved, and we're very happy to have you. Most of our speakers were involved in writing guidelines. They are the ones to talk to. Please, can you just introduce yourself?
Yeah, good morning. My name is Mark Sklansky. I'm hoping you can all see my slide. Are you able to see?
Yes, Mark.
Great. And are the videos moving?
Oh, no, it just disappeared.
Well, we did not apologize for that. We did not check this before. So let me try a desktop approach.
Perfect.
Well, I don't know if is the video moving?
Yes.
Yes.
It is. It's moving.
Yes.
So listen, thank you for inviting me, Rima. It's quite a pleasure to join Mary and Anita and our other esteemed colleagues here. I'm going to speak briefly about some thoughts on current status from some of the guidelines of fetal cardiac screening. I'm happy to see, Rima, you brought representatives from other countries to hear about their approaches. But the heart is the same regardless of where we are on the planet. And the kinds of heart disease generally the same. So I do have, having been practicing for 35 years or so, I scan all my patients and just have some ideas in terms of how to screening approaches, and I want to share with you those and compare it with a couple of the guidelines that are out there in terms of fetal cardiac screening. As you know, the reality is that most hearts, when we look at the fetal heart, it unfortunately does not look like the heart in the upper left. Rather, at least when I scan, it looks more like on the upper right. And I think if babies looked like on the upper left right away, we wouldn't be missing so much heart disease. I think this is one of the most important, if not the most important reason why heart disease is so hard to pick up, is that we have limited amount of time for those who screen and limited windows. Often we typically have degraded acoustic windows and limited time, and I think that's a big issue. It's an issue around the world. So I just start with a little case I'll come back to later. This was a real case here in LA, 19 weeks, low risk pregnancy, anatomic survey. You can see the 4-chamber view with and out color. You can see the crossing over in the bottom right, and then you can see the LVOT in the bottom left, the RVOT. I just didn't find a good clip to show you. And there was something missed at this study. and I'll come back to that later. So this, again, fetal cardiac screening is near and dear to my heart. It's been focused on my career as a pediatric cardiologist for 35 years. And so I'm going to share with you some thoughts of my own. But the bottom line is, again, if every fetus, when we looked at the heart, if every fetus just looked like this on its own, I don't think we'd be having the kinds of problems we're having detecting heart disease the way that we are now. But the problem is that they don't look like that. And usually we face what I call degraded acoustic windows. And so I think the guidelines generally around the world assume two things. First, unlimited time, and two, exaggerating a little bit, but you get my point. A lot of time and perfect imaging, so you could see everything. So if you could see everything and you have the time, what should you see? And I think an issue is that typically we can't see everything very well, at least not in the time that practitioners have. And so this was an effort, this paper, to start a conversation about the importance of optimizing the image and the angle, and then thinking about when we can't see everything, what's the most important thing to see, and then what do we do when we can't see what we have to see. So, I mean, I think all of you all listening probably know how to optimize the image, but this is something that is really very important and should not be assumed by guidelines. And I'm happy to see guidelines increasingly incorporating some strategic approaches to optimizing the image and the angle, and not just to assume it. Always to choose the best probe, optimize the probe position on the abdomen, which of course changes based upon the time and based upon what structure you're looking at or what view. Optimize the maternal and fetal positions, mom on the left, mom on the right, or have the mom go to the bathroom, jump up and down, whatever, just to see if we can change the fetal position. And then of course, optimizing pressure, really important. A lot of people who practice don't really push as much as they should. I like to use two hands so I could press just the right amount and hold it just so. And I use a foot pedal to help me acquire clips while I hold two hands on the probe. I find that really helpful. And then of course, optimizing depth and sector width and zooming so that the heart takes up most of the space. These are basic concepts, but really important. And I think we still need to emphasize that in our guidelines. And then also angle of acquisition. I mean, this is really key and something that I don't think initially when I was working with 3D imaging in the 90s, we thought it would be independent of angle of acquisition. It's not. And even things such as AI, I don't think are going to be angle independent either. But this is, you could all see what we're looking at here, which is I think it's a mirage. I don't think it's real water, and you probably think it's a mirage, but how do we know if it's a real water or not? You need to get closer to it and then it disappears, or you just change the way you're looking at it when you're driving in the car. Same thing for imaging, say a VSD. How do you know if it's a real VSD or not? You have to get close to the heart and you have to look at it with the right angle. So angle of acquisition, optimizing the image. This is not, in my opinion, the way to evaluate outflow tracts or the septum. You don't want to be parallel. I believe it's best to be relatively perpendicular. This is my favorite view on imaging, with the LV on the bottom. I think it's better to have the aorta coming sort of towards the probe. So I like this view a lot. I strive to get.
Mark,
Yeah.
we're not seeing any of the images. We're just seeing you.
Talk.
Yeah.
That's not, I can see him and the images, Rima, so.
Okay, everybody, I'm sorry.
I can as well.
I've got
Okay.
the images.
Okay, it's me. I'm sorry.
Sorry, Rima. Sorry, you just have to listen to my voice. Sorry.
Oh, no.
And then this the outflow tracts relatively perpendicular on the left. You could see a normal LVOT continuity from the septum to the aorta, a nice looking aortic valve that disappears during systole, nice and thin and delicate with during diastole. Then on the right, you could see an overriding aorta. And then my favorite view in 2.0 is just with a little tweak of I say just, it takes some practice, but a tiny bit of motion with the wrist, and you go from the outflow to the inflow, so you can make sure that the crux is intact. There's no inflow VSD, and this is so dependent upon angle that almost always you'll see dropout in the inlet septum if you're parallel. So getting to guidelines, so of course, I'm just showing a couple of guidelines in this talk. The ISWA guidelines came out in 2023, 5 transverse planes, which is a wonderful way to approach screening, in my opinion, starting in the abdomen and then 4-chamber LVOT, RVOT, and 3-vessel view. And the ISWA guidelines in 23 recommend those planes with cine clips, not just stills. Color Doppler is just recommended, but not required to the same degree as the transverse planes themselves. It's just a quick example of in the abdomen, then coming up from the stomach, descending and IVC up to the heart. So you see the stomach and heart on the same side, descending and IVC, and then the heart with the apex 45 degrees leftward. And then I'm going pretty quickly, just in the interest of time, 4-chamber view, of course. And again, it's not really one 4-chamber view. It's probably going to be more than one 4-chamber view. But here's examples. And I'll pause here just to emphasize another concept I think is important, that when we have degraded, that I think guidelines should approach, is the concept of looking at structures rather than views. Pretty much screening guidelines talk in terms of views. Fetal echo guidelines, which Mary and the others will discuss, go in terms of beyond views, but also the structures. And I think when we have degraded acoustic windows, ideally, whoever's doing the scanning should start to think in terms of structures, not just views. Here's the LVOT and RVOT crossing. Here's the RVOT and the 3-vessel view, just going from the 3-vessel views all the way to showing the left. It's a left arch. So here's screening guidelines, at the liberty of putting the paper I mentioned earlier, because I do make some recommendations that came out in 2022. Again, talking about what happens when you can't see the heart very well. And then ISWAG in 23, and then AIUM came out in 2024 with their own guidelines for fetal cardiac screening. And on the left, and you can, I hope you all can see this, but in blue are what I believe, my personal opinion, on what are really key aspects of screening, clips, color flow, and this is for all cases, which most cases will have degraded acoustic windows. And I think in all cases, we should be looking at clips. We should be doing clips, color flow imaging, the 5 transverse views that we mentioned. Angle of acquisition is important to focus on, scanning techniques to optimize image quality, and some assessment of ventricular function. Just is the heart squeezing? Is there ventricular function or not? You know, it's just at least very elemental. And if you look at the guidelines, so I recommend that in all cases, especially when you have degraded acoustic windows. ISWA guidelines do not recommend color flow to the same level as the transverse. And I believe color flow should be an integral part of screening. And then also do not mention anything about looking at ventricular function. And the guidelines from AIUM in 2024 do not even recommend clips, that should be black, or color flow imaging. 3-vessel view is still technically feasible. No discussion of angle of acquisition, no discussion of scanning techniques, and no mention of looking at function. So my opinion, I'm going through this really quick. Obviously, there's a lot of discussion and thoughts, although the focus of today will be on fetal echo, but I think that the screening is really important. And these are areas in black that I think these guidelines, I'm hoping, will incorporate in the future. In my point, most important for screening in all cases, but especially with degraded acoustic windows, is to optimize the image quality, optimize the angle, use color flow, especially when it's difficult to see the heart, sort of like first trimester. It's hard to see the outflows. You certainly want to use color. And then clips and sweeps. And then less important, in my opinion, are quantitative measurements. And but also they can be quite important, of course, but not before you've optimized the image and the angle, because you want the quantitative measurements to be reproducible. And if they're not, and if they're erroneous, they could be actually misleading and take time away from optimizing the image. So views or structures, again, I sort of alluded to this earlier, with optimal imaging conditions, which is what guidelines generally assume. screening, we talk about views. Fetal echo, we talk in terms of views, but we go beyond that and talk in terms of structures. In challenging imaging conditions, in my opinion, for screening and for fetal echo, ideally we should be thinking in terms of structures. And why is that? It's because if you have optimal imaging and you're looking at the 4-chamber view, it's pretty easy, like in the bottom left, pretty easy to see all the structures that we want to see. But if you have degraded acoustic windows and you get a 4-chamber view, it's likely that you're not going to see part of the 4-chamber view. You might not see the mitral valve well, or the crux well, or the apex well. It's more likely, if you have degraded acoustic windows, to have a poor quality 4-chamber that does not really show what you need to show. So that's why I think it's even more important to think in terms of structures than when you have optimal imaging. So this is just lessons from bird watchers. I don't know if any of you like to watch birds. I think my guess is you do. So here's a bird. So what goes through your mind? What goes through your mind when you're trying to figure out what kind of bird this is? What is your brain doing when you're looking at this bird? So this happens to be a Western tanager. I don't know if you have them in Rome or wherever you're watching. But what's the point of it? Well, when you're looking at the bird, you're looking at the head, the beak, the breast, the tail. You're trying to see the different structures to figure out what kind of bird it is. You're not thinking, oh, I need to get an anterior view. I need to get a lateral view. I need to get a posterior view. The views are not important in of themselves. You're doing that because you want to see the tail, or you want to see the breast, or you want to see the beak. So that's the way I think we should be thinking about screening the fetal heart. Everyone should keep in mind the views are just tools to seeing the structures. The views are not important in and of themselves. But of course, when you're learning, it's easy to think about views, but I think clearly around the world, we need to do something different. We need to get better at screening. And I wouldn't put all of our eggs in the AI basket. So what is fetal scanning, riding a bike, and writing? What do they have in common? Here's a little girl learning to ride a bike. Here's someone learning to draw C's. And of course, the answer is that we could have these webinars and have conferences and have people read textbooks, but you have to do it. You have to scan, just like you have to get on a bike and you have to put a pen in your hand to learn how to do these techniques. So whenever we have conferences, I just had my 15th last weekend. We try to have hands-on scanning that's so key, and just go to people's practices and teach how to do hands-on. So no, I'm covering a lot, but just in the interest of time and respect to all the other speakers, since I'm going first, I want to make sure to cover everything. So just getting back to this case, I don't know if you have any thoughts, but I said that something was missed, and it is true, something was missed. They did these routine clips. According to the guidelines, this certainly met the guidelines, but missed. This is 19 weeks, the LVOT, and then this is 28 weeks, just a routine growth scan. So this baby had valvular aortic stenosis. The aortic valve just was not, people were not thinking of the aortic valve. It was sort of an incidental finding, part of the LVOT. It wasn't really optimized in terms of the angle. People weren't thinking of the structure, and a relatively subtle structure abnormality that may have been detected had the angle and image been optimized was missed. Baby developed severe cardiomyopathy secondary to the aortic stenosis. So here's just an example, just showing you 19 weeks of the LV, and then 28 weeks the LV. So here's my email. Happy to correspond with any of you. But again, I know this was a quick tour of just a couple, talking about ISWAG and AIUM guidelines in terms of screening, giving my own thoughts in terms of where we might want to make some modifications in the future to help improve detection of congenital heart disease around the world. 7:20. So thanks again. I look forward to hearing Mary and the other speakers and having some discussion.
Thank you so much, Mark. And I think we are not going to open the floor for discussion until Mary starts her talk. It's very nice, it's very thoughtful, and you put a lot of energy and thoughts in what you're showing. Thank you so much. Mary, do you want to start? And Mary D'Onofrio is also a very well-known figure in fetal cardiology, and she's the former head of the Fetal Heart Society. And she's a medical director of prenatal cardiology at Children's National Hospital. And she's also one of the main authors of the guidelines of fetal echo. Please go ahead.
Thank you, Dr. Bader. Mark, so well said. Oh my gosh, that was really a beautiful talk. And what I'm going to talk about is the most recent kind of up-to-date way of thinking about the heart um, when there is an abnormality. So the fetal echo guidelines that have recently come out, what's new is really how to assess the heart when there is an abnormality. But I love that you're sort of taking what we're thinking about at looking at the specific structures and using the views as a tool. It's a really great way to start thinking about how perhaps we should do screening. So I love it. So my objectives will be first to touch on kind of what Mark talked on, at least in the United States. There is a difference between looking at the heart as part of a screening exam. So on that screening cardiac exam, really what we're going for is detection of congenital heart disease in low risk populations. And it is typically part of an obstetrical exam. Then the standard fetal echocardiogram, where all the guidelines up until the most recent ACE guidelines, as far as I know, when we have talked about the standard fetal echocardiogram, it's to detect congenital heart disease in a higher risk population referred for some sort of indication. And in this instance, again, in the United States, it's typically done by a specialist, whether it's a high risk obstetrician, so a maternal fetal specialist, perinatologist, or done by a cardiologist. The ACE guidelines, which were published in 2023, go beyond that. And really, we're using fetal echocardiography as a comprehensive assessment of the heart that includes the structure, the function, and the rhythm once an abnormality is detected. And so you already saw this. I think the ISWA guidelines were for screening were really a jump forward for us as a profession, saying that the four-chamber view is inadequate. And really what needs to happen is to sweep the heart from the level of the diaphragm up to the three-vessel trachea view. And as Mark showed, there are 5 distinct views that can be used. When you look at the components, what these guidelines really say is you're not just taking a snapshot of the four-chamber view, but looking at specific features, including laterality, how big the heart is, and then looking at the atria and the ventricles as 2 of the segments of the heart, and then the AV junction. So a lot of information in that four-chamber view. But then just as important then is to leave that four-chamber view and head towards the LV outflow, the RV outflow, and the great vessel view, which is the three-vessel view and the three-vessel trachea view. As Mark said, video clips are recommended but not mandatory, and I frankly think that that should be our next step, and certainly color as well is optional. These guidelines that came out for fetal echo, so again, this is different than the cardiac screen that you just heard about. I joined the AIUM group in 2013 to write those guidelines, and then soon thereafter, we put together the HA statement paper that did include guidelines for performing a fetal echo, but that went further to talk about care of the fetus with congenital heart disease. What I love about these initiatives was that it was a true effort for collaboration, acknowledging that there are different specialties that perform a fetal echocardiogram, and everybody really should be striving to do the same thing. And it took a lot of effort to come to agreement, but the cross-discipline mandatory elements included 2D imaging of the chambers, the valves, and the vessels, and video clips are mandatory. Biometry, a lot of discussion here, but for a fetal echo, measuring the 4 valves at a minimum. Color is essential and mandatory of the valves and the vessels coming in and leaving the heart. Pulse Doppler is mandatory for the valves and the ductus venosus, and not just assessment of heart rate, but heart rhythm, as well as an assessment of heart function. And all of these guidelines talk about using a segmental approach to assess the fetal heart. I think AIUM in the 2020 revision went further than saying, okay, just take a moving picture of the heart. You really need to require specific video clips and try to give recommendations on the minimum number of video clips. But again, as Mark said, looking at specific structures is key beyond looking at views. But the minimum views is to sweep the heart from the abdomen up to the 3-vessel trachea view. And frankly, that is the cardiac screen. So I think every fetal echo should start with that cardiac screen. And then looking at each view with a video clip, both in 2D and in color. So the 4-chamber left outflow, right outflow, and 3-vessel trachea view. And then moving on to the arches, as well as the SVC and IVC. The diagrams were the same for both of these writings on purpose, and Mark has already showed you this. But frankly, if we could get everyone to do this initial sweep as part of the cardiac screen, both in 2D and color, paying attention to the structures, I think we really would not be missing congenital heart disease. But it is the starting point for the fetal echocardiogram. And then moving to different views to sort of further look at each one of the structures. This is the on top, the short axis view defined as high, which is at the base of the heart, and then lower down at the apex of the heart, and then rotating 90 degrees perpendicular into the long axis view. And so what that looks like is the short axis view will show you this nice little aortic valve as a circle with the RV outflow tract curving around it. As you head down towards the apex of the heart, you can see the mitral valve, the left ventricle in cross section to look at function, and then the right ventricle as a crescent kind of surrounding that left ventricle. Rotating 90 degrees, this is Mark's favorite view, is the long axis view where really you're highlighting that the left ventricle and the left ventricular outflow tract and shows the those structures, including the interventricular septum nicely. And then moving to the sagittal views, SVC and IVC, and then the 2 arches. I think it's very important to do video clips of the arches to kind of move out of that still frame, saying the arch is normal, to truly look for trouble, and then overlaying color to look for flow disturbances. And then the ductal arch view in a slightly different angle, showing that ductal arch connecting the main pulmonary artery to the descending aorta. Okay, so in 2023, I had the privilege of co-chairing this writing group with Dr. Anita Moon-Grady, who is on this call, and really led this group to put together, in my opinion, which is an amazing document that is really just full of information, is meant to be used as really just not just the guidelines, but really educational to say, if you're going to look at the heart and make a diagnosis of congenital heart disease or a cardiovascular abnormality, you really have to look at multiple things and truly understand. So this is a specialty field. And I think in the United States, we're lucky enough to have specialists to do this. But certainly, I think in other parts of the world, there should be hubs where this kind of imaging can be done. So these guidelines extend beyond the standard guidelines to include a really thoughtful process of indications. So who should get this specialized test? And as Mark said, image optimization is important. Early fetal echo is now becoming something that we do. So, how do you do it and what should you expect? And then really diving into an assessment of both rhythm and cardiac function in both normal situations, but then what do you do when it's abnormal? And then finally, how do you assess structural heart disease? It's not just taking those standard views, but it's lesion specific recommendations, then with view specific findings. So this is one of the tables. There's lots of them in there. And again, I think using it as a reference is what we intended. But really, the indications for referral are listed here. There's really no surprises. And we tried to compare what we were recommending to the other guidelines of AIUM and AHA. So who should get a fetal echo in both the maternal risk factors and then the fetal risk factors, which are down here. A couple of differences from what these other documents have said. So I just want to highlight those. IVF, we have dropped it in the most recent guidelines from it's mandatory to refer a patient for a woman for fetal echo. It's not mandatory, but maybe should be considered depending on local resources. Ones that we took off the list because there really is no data saying that their risk is higher than the general population risk included family history of congenital heart disease and second degree relatives, obesity, lithium exposure, and the single umbilical artery. So we felt that fetal echo was not indicated. Why did we change this? Well, the recommendation for these guidelines were based on pre-test probability of risk to the general population risk. And what does that mean? What that means is the new guidelines take into account the risk after a normal anatomy scan with cardiac screen, which you just heard about, is obtained, which suggests that the heart is normal, and that's done during the obstetrical exam. And acknowledging that certainly this is dependent on local resources, the quality of that OB scan, and the accepted cost of identifying congenital heart disease in these low-risk populations. And so then this is not just country dependent, but it's also actually in our country region dependent. I think all of us agree that the definite reason for referral is when somebody is concerned that something's wrong. That is the highest risk indication where referral should be made. Okay, so again, Mark did this much better than what I'm going to say, but certainly image optimization is key. High frame rates are needed, at least 30 to 40 hertz, even higher if the heart rate is greater than 140, or if you're delving into specialized imaging. Magnification is key. The heart should be at least a third of the imaging display, the focal zone set to the region of interest. And again, the imaging planes are important. The septa should be imaged perpendicular to the ultrasound beam, and color and pulse Doppler interrogation should be parallel to the ultrasound beam. And then parallel Doppler, if you have it, can be used to interrogate small vessels and septal defects. A little bit about early fetal echo. The timing, typically greater than 10 weeks, but usually around the 12 to 13 week mark. Endovaginal imaging is often needed. So if you're going to be looking very early, having this resources of endovaginal imaging is important. Once you get beyond 12 weeks, ideally 13 to 15 weeks, in most instances, transabdominal imaging is adequate. These should be the highest risk patients, so the same indications, but at the higher level of concern. And the expectations based on experience and published literature is that the four-chamber view most often can be obtained. The great arteries obtained as well in most instances, particularly if you use color Doppler, and we acknowledge limited imaging of both the pulmonary and systemic veins. As far as cardiac pathology goes, in experienced hands, the sensitivity was, in the literature is 78% with a pretty high specificity of 98%. It is still considered a screening exam, And these guidelines recommend a follow-up fetal echo after 18 to 20 weeks. Okay, so now looking at the essential elements, again, no real surprises. If you look at the two-dimensional required elements, they're pretty much the same as what I already mentioned. Looking at the cardiac position, the situs, the veins and the arteries, the chambers, and all four valves. Looking at color, required color, again, not much different than what has been previously published. Looking at the systemic and pulmonary veins with color, and then the AV connections, the valves need to have color, the septum, the chambers, and the great arteries. The only change that the group felt was important was to require a quantitative assessment of cardiac size by measuring the cardiothoracic ratio. And so this, remember, is for a fetal echo, not for that screening exam. Looking at pulse Doppler, again, not much different than what has been previously recommended as mandatory elements. Looking at the four valves, it's important to use pulse Doppler to interrogate those valves. The ductus venosus has also been listed as a mandatory element. We felt that the ductus arteriosus should be a mandatory element, so that's a slight difference. And the group felt that Doppler of the umbilical artery and vein should be added to the standard fetal echocardiogram, particularly when there is an abnormality present. And that is different from the past guidelines from AIUM. We have a nice picture. It basically is the same as the other picture, except now it's color-coded, and really to show as you sweep from the abdomen up to the three-vessel trachea view, where are you and what should you see? So that's the color coding, which I think really gives a nice touch to this diagram. And then if you go online, there will be video clips showing what you should see. So the four-chamber view, here comes the left outflow tract and the right outflow tract in that crossing. And then once you get up to the three-vessel view, where you see the branch pulmonary arteries and a little bit more cephalad to the three-vessel trachea view. This is a nice new diagram looking at where the imaging plane should be when you look at SVC, IVC, and the two arches. But what's nice is we threw in where the valves are in relationship to this. And then again, the short axis view, both low and high, so at the base and the apex, and where the valves are in relationship. And again, some video clips added of what the SVC, IVC should look like. Here's a nice picture of the aortic arch, the ductal arch, and also kind of the short axis view here with the aorta in the middle, and then heading more towards the apex, showing that short axis view down towards the apex. I think Doppler, it's not good enough. We felt just to say you should Doppler all these things, but we really wanted to show examples. And so here's examples of all the normal Doppler from the veins, ductus venosus, IVC, and hepatics, but also the inflow valves. Here you can see mitral valve underneath, two peaks, second bigger than the first. The two outflows, the aortic outflow is here. The pulmonary outflow is here, adding in the ductus arteriosus and branch pulmonary arteries, the all-important pulmonary veins, and then the umbilical artery and vein. And then again, because we were trying to say what happens when it's abnormal, what should you be looking for, in particular here at the veins, showing how you have changes in the venous flow patterns as you develop signs of right ventricular dysfunction, and these all represent elevated right atrial pressure. So what happens to the IVC flow? You get more reverse flow during atrial systole, ductus venosus, and umbilical vein as well. Usually the changes happen during atrial systole where you end up with reversal of flow. So as far as biometry goes, again, we felt like it wasn't good enough just to say you should measure things. We really wanted to offer not just guidelines, but again, really a reference to kind of say, how should you measure these things? How do you do it correctly? So the starting point was heart rate and rhythm. That's kind of a new thing. How should you do it? An example here is mitral inflow, aortic outflow. So you need to see what the atrium is doing and make sure the ventricle is following. So AV synchrony is important in the assessment of rhythm. And then when you measure cardiothoracic ratio, again, that's a new thing. How do you do it? Measuring the thorax and then the heart. And what it's important to get this for different diagnoses. The valves, again, measure them, but how do you measure them and what views? The standard is to measure valves with them open in the United States at the level of the annular plane. So this is how we do that. And then for these optional measurements of the size of the ventricle, the size of the atrium, we wanted to include these optional measurements. And then the measurements of the important arteries, the main and branch pulmonary arteries, the aorta, in particular, the aortic isthmus. Rhythm assessment. So how do you look at rhythm? There's different ways, but again, looking at what the atrium is doing simultaneous with the ventricle is important. Usually some sort of Doppler is the best way to do it, and there's multiple ways to do it. SVC aorta, mitral valve, aortic valve, and pulmonary artery and pulmonary vein are probably the most common. You can use tissue Doppler, and then here is M mode through the atrium and the ventricle. But what's important is to look for AV synchrony. And then again, in the spirit of looking at abnormal rhythms, we give examples of fast rhythms. So this is atrial flutter with the atrium beating about 400 times a minute with 2-to-1 conduction, whereas this is SVT with 1-to-1 conduction. And then when the heart rate's slow, what are some examples here? This is an example of heart block with a faster atrial rate and the ventricle rate lower. And then we even went a little bit further to say when the heart is beating fast or irregular, what's important to look at when the heart is beating fast, what is the differential, and what are the best views to identify that differential, M mode or Doppler, and then other findings. So looking beyond the rhythm to try to say, well, what would the rest of the fetal echo show? Same thing for bradycardia. There are different mechanisms. So how do you distinguish between them? Function assessment. We really wanted to go beyond just qualitatively looking at function. As Mark said, it's important, I think, to look at function on the screening as a qualitative feature, but when you're drilling down into a fetal echo that's abnormal, how do you assess systolic function? There are different ways. Diastolic function, again, multiple ways. You can look at, are the valves leaking? You can measure cardiac outputs. We tell you how to do it. And then how to calculate the 10-point cardiovascular profile score. And then again, going further, when do you need this high-level function assessment? There are different kinds of hemodynamic derangement, high cardiac output problems, increased preload, which is a volume overload, increased afterload, and if the heart is compressed. So what are the conditions where you might see these things? And then how do you assess it? So again, comprehensive look at heart function. And then finally, looking at the heart when it's abnormal, segmental anatomy. What is that? We keep talking about it, but what is it? And then we delved into lesion-specific recommendations, picking the kind of most common categories of defects, including single ventricles, AV valve abnormalities, what we call the look-alike outflow tract abnormalities, lesions that progress, and arch abnormalities. And then because people still think about views, what are the view-specific findings for each one of these lesions? So in the 4-chamber view, you can see here, obviously this is an AV septal defect, but you do need to look at the rest of the structures if you start and you see this abnormality. This is transposition of the great arteries, which is the example here of the outflow tract abnormality. This 4-chamber view would be normal. And then finally, in the 3-vessel view, trachea view, this is a double aortic arch. And in this view, this abnormality, the four-chamber view, and the LV outflow tract view might be normal. So it's important to sort of look beyond one view and assess all the views when you're looking at congenital heart disease. Okay, just as far as segments go, really the segments of the heart are the viscera, the atria, they usually go together, the ventricles and the great arteries, but there are connectors in between them. The veins connect the viscera to the atria, and then for the atria, there's the AV relationship and the AV valves, the ventricles, the VA relationship, and then the semilunar valves, and then there's the great arteries. So how do you assess the viscera? Where do you look for it in a single axial sweep? The venous connections, where do you find those veins in the bicaval view and the four-chamber view? And then the atria, the AV relationship, and the valves, typically in the four-chamber view, and then the ventricles as well as the four-chamber view, but you can use other views. Mark showed that nicely. And then as you head up towards the outflow tracts, the VA relationships, the semilunar valves, and then finally the great arteries. Okay, so some examples of an abnormal four-chamber view, valve stenosis. It's going to start with ventricular hypertrophy and then lead to ventricular dilation. Mark showed an example of this, but then progress to ventricular hypoplasia. So progression of a dilated left ventricle to a small left ventricle. We think of this as evolving hypoplastic left heart. For valve regurgitation, the right atrium is going to be dilated. So in that four-chamber view, when the RA, right atrium is super big and the valve is leaking, you have to think about Ebstein's, versus if the right ventricle is dilated, you need to think about the pulmonary valve leaking. So this is a case of TED absent valve. When you go to the outflow tracts, quickly, the lookalikes, this is double outlet right ventricle with both of them coming off the RV, but they are side by side, and there's a VSD there. So that can look kind of similar to other things. Here's a big VSD with a single blood vessel. So that's truncus, which looks very similar to tetralogy of Fallot. And then those parallel outflows can be D transposition, or frankly, can be L transposition, but then you have to go back to the four-chamber view to see that the ventricles are inverted. And then finally, the three-vessel trachea view. Here's normal, where it comes together like a V with with the colors showing the same direction. If you can't find the aorta, there's either interrupted arch or coarctation. If the ductus is small and then it bulges out, this is a ductal aneurysm. And if something's to the right of the trachea, you have to think of a vascular ring. So just some examples of the three-vessel trachea view being abnormal. And then finally, we do acknowledge that lesions can progress, and this is a table that really shows anything can change. So serial imaging is important. Inflow-outflow obstruction, inflow-outflow regurgitation, the ventricles, valves, arteries can get smaller, or they don't get smaller, they just don't grow. So the relative size gets smaller. The framing can become restrictive, so can the duct. Tumors can progress or regress. The chambers can dilate further. The ventricle can stop working. The heart can fail. Arrhythmias can occur or resolve, and VSDs can get smaller and even close. And then I'm not going to go into it, but a nice finishing touch of these guidelines is to say when you identify a problem, how frequently should you follow them? These are the diagnoses and how frequently you should look at them through the pregnancy, and in particular at the very end for delivery planning, we make recommendations for that. So in summary, fetal cardiac imaging guidelines, I do think should be multidisciplinary and collaborative and should continue to evolve as our discipline advances. We really need to work together to take care of these patients, and it does start with the screening test, as Mark stated. These guidelines really are updated really to help us further once a diagnosis of congenital heart disease is made. They're evidence-based indications. when should you look, how frequently should you follow these patients, and really detailed recommendations for imaging the abnormal heart. And then finally, recommendations for image-based in utero and delivery room care. Thank you so much for your time.
Thank you so much, Mary. You made a very difficult task sounds very easy. I'm sure it's a lot of hard work. And for the sake of time, we're going to postpone the discussion till all speakers talk. Please allow me to introduce our next speaker, Dr. Hikaru Matsui. He is the current president of the Japan Fetal Heart Society, and he's also a member of the university in Japan. Dr. Hikaru, are you there?
Yeah, I'm here.
Can you introduce yourself better than what I did? I'm sorry for that.
Yeah, it's okay, but hello everyone. My name is Hikaru Matsui, and I'm a new president of the Japanese Society of Fetal Cardiology. And thank you very much, Mark and Mary. Very great, nice presentation about the screening and fetal cardiac imaging. And I wanna start my short presentation about current situation of guideline of fetal echocardiography in Japan. Can you see this my slide?
Yes, everything is well.
Sure.
Everything, yeah.
Yep. Hello everyone. Thank you so much for this valuable opportunity. My name is Dr. Matsui, and I would like to talk about the history and the current situation of the guideline for the fetal echocardiography in Japan. First, let me briefly introduce our society. The Japanese Society of Fetal Cardiology, or JSFC, was established in 1994. At present, we have more than 1,100 of members, including more than 400 of cardiologists, 600 of obstetricians, and 100 of medical staff. JSFC is a subspecialty of the Japanese Society of Pediatric Cardiology and Cardiovascular Surgery. This slide shows the history of our society. Our first annual meeting was held in 1985, and we already had the 32nd annual meeting this year. We have invited many guests of fetal cardiologists from North America and Europe. And in 2006, we published our first fetal echocardiology guideline. The first Japanese guideline was published in 2006 in Japanese. It is some kind of standard procedure manual rather than making a strict guideline in today's style. At that time, our main goal was to standardize fetal echocardiography and to spread its use widely across Japan. In 2015, we translated it from Japanese to English. The next step came in 2016. Dr. Donofrio had reported the AHA scientific statement in circulation, and it was very informative for our practice. We asked AHA and Dr. Donofrio to have a permission to translate the statement from English to Japanese for spreading it in Japan. We made a special book which includes the AHA statement of both English and Japanese version, and our first guideline of both English and Japanese version. We sent the book for all members of our society for free. Then, in 2021, we published the second edition of the Japanese guideline. The English version followed in 2023. This updated guideline includes the practical management and clinical questions for the fetal echocardiography. In our guideline, we define fetal echocardiography in 2 levels. One is screening. We call the level 1 scan, mainly performed by obstetricians or sonographers. The other is diagnosis. We call level 2 scan, mainly performed by fetal cardiologists. The chapter in the guideline covers screening, detailed examination, cardiac function, perinatal management, arrhythmia, and ethic and support. One of the unique and important points in our guideline is image orientation. The actual image is to be shown as a look-down view. This means we always look the fetus from head to the feet. This is always to detect the left side and right side of the image consistently. Now, I will briefly show the content of each chapters. For level 1 screening, basic screening is performed in 5 steps. Recently, advanced screening add extra view to detect more difficult regions, such as coarctation of the aorta or total anomalous of pulmonary venous connections. For level 2, the detailed scan, the fetal cardiologist makes a special diagnosis by using the multiple views. This is a key step of perinatal management and postnatal care. The guideline also covers the fetal cardiac function, and we also describe the perinatal management and delivery planning for the fetus and mothers. We also include the chapters on perinatal diagnosis and treatment of arrhythmia, and finally, ethic and support. A new feature of this second edition is the clinical questions section. We selected some basic clinical questions that comes up in daily practice. For each question, we provide a draft recommendation and the strength of evidence. These are basic topics of fetal echocardiography. We hope we can show the further evidence. Beyond the guideline, JSFC is active in several projects. We are making a guideline of transplacental treatment for fetal tachyarrhythmia, which will be available soon. We are also translating the ASC fetal echocardiography guideline into Japanese. We have doing the many projects for fetal cardiology in Japan, including the guideline. We hope further collaboration around the world. Please feel free to contact us anytime. Thank you very much for your kind attention. Thank you.
Thank you so much, Dr. Hikora. It's a very informative talk, and for the sake of time, I'll move to the next speaker, and that's going to be Dr. Simona Pedra from São Paulo, Brazil. Are you there, Simone?
Can you hear me?
Hello.
Hello.
Simone, can you introduce yourself in a better way than what I did?
Sure. So I'm Simone Fontes Pedra. I'm from Brazil, São Paulo, and I'm a pediatric cardiologist and fetal specialist. Now I'm running a program in São Paulo, a public program, which is Dante Paganese of Cardiology, and I have a private practice, which I work on not only on fetal but on pediatric cardiology in general. Okay.
We must say that your center has done quite a lot in South America in terms of interventional fetal cardiology. You and Carlos have done a tremendous job in with having excellent results as well. Would you please proceed with your talk? I have a note here from someone you like. He said you're also a beautiful singer.
That's right. So thank you. Thank you, Rima, for being part of this, and thank you everybody for the great talks. So I'm just talking a little bit of the way we screen and we diagnose congenital heart disease in Brazil. Of course, very, very similar to everyone.
Can you put the Simone? Can you put the presentation in the presentation mode rather than slides mode? Just click on the right.
It is. For me, it is. Isn't for
Okay.
Is it for everyone? Can Mary? No, it's not.
No, it's not. Are
It's
you
not.
sharing the correct screen? Maybe you have to share a different screen.
Okay, let me see.
Maybe
All right.
that.
I'll do it again.
Then click at the bottom.
Well,
No, the first one. Yes, you're there. You're there. Just move to the right. Move to the right. Move to the right. You're down.
I can see that. I can see that. Sorry, let me try again.
Share screen, and then
Advanced. No, documents. No. Screens. So currently. Layout.
okay. If it doesn't work, it's fine. You just
Yeah,
that's fine. That's fine.
fine?
That's fine.
Okay. Okay, sorry. So just to give an idea, in Brazil, the prevalence of congenital heart disease in our population is expected to be around 30,000 babies born with congenital heart disease every year. And you know, Brazil is a continental country with low access to ultrasound and prenatal care, mainly in the north, northeast, and central-west parts of Brazil, and among low-income population, even in the big centers like São Paulo and Rio de Janeiro. So there is a big part of the population that have no access to ultrasounds, and sometimes not even for maternal care. So the prevalence and detection rates are not consistently known, and it's very heterogeneous around the country. So there are many training programs for MFM specialists, OB, and radiologists, and they are, of course, mandatory and has been part of our fetal specialist best practice to improve diagnosis and prenatal congenital heart detection. So Brazil is, as you know, very big country. This is the area that it's the poorest area. It's the north of Brazil, and there's a big lack of diagnosis and, of course, of care in this area. Northeast, it's a huge area too, very poor, but there are some centers, and Central West. This is another big area, includes part of the Amazon forest, and there is a low diagnosed rate there. So the biggest centers are in São Paulo, Rio Grande do Sul, and Minas Gerais, and some in Paraná, and Rio de Janeiro, and Espírito Santo. So north and south and southeast of Brazil. So the thing is not only the diagnosis, but the possibility to treat. this population.
Simone,
Yes.
the screen is not moving. So I would advise that you go out and go in again and share. Yeah. And yeah, exactly. And try to, so because you have beautiful slides and they're just not coming.
Yes.
You know, I just wanted to suggest you may want to go to a presentação, the slides presentation. Pardon my pronunciation.
No, you know what? I have here screen.
It's a bottom
Entire
left.
screen
or bottom.
application window. Is it application window or entire screen? I can't, you know.
No.
every time
First of all, share screen. Number one, share
Yes,
screen.
I'm there.
And
The
when you
entire screen. Do the entire screen and then open your presentation.
The thing is that I can't. I don't find it to look at it. Entire screen.
would you share the screen and we'll show you where to click. Just share the screen. And try to come out of the image because yeah, and then okay, you see where it says at the very bottom to the right of the screen where you can increase the size of the image or not. There are 4. Yes, exactly.
Yeah,
Move there.
I
Yeah,
know.
this one exactly.
I've been
Yeah.
doing that. I've been doing that. Let me do it again.
Can you double click, please?
Did it go?
No.
Yeah, I'm doing that. I don't know
Okay.
what's going on. So the slides are not moving, so let me do that.
So I would advise, yeah, you go one by one
Yes.
manually.
Okay.
Yes.
Okay. So this was Brazil. And then I'm moving to the next slide, which there is a funny thing here. In June 2023, fetal echocardiography was included as part of the prenatal care in public health system. This was a law sanctioned by President Lula that included transvaginal ultrasound and fetal echo. So I'm sure he wasn't very, there was no specialist with him, so we didn't understand why 2 transvaginal ultrasound and fetal echo. I believe that was, the proposition was to include 2 morphological ultrasounds, the first and the second trimester, and included the fetal heart. So besides that, the prenatal detection rate of congenital heart disease in Brazil is still very low, 10 to 30%, and less than 20% of complex heart disease are diagnosed. So I work in São Paulo. This is the biggest and the richest city in São Paulo, and the center I'm running is one of the biggest ones, and in this scenario, there is still a very low rate, and the babies are transferred to our tertiary center in a very unstable and hemodynamic condition. So there's a big difference from private health care, as I'm going to show. Regarding the referrals indications, so we have our guidelines that was published on 2019 and includes all the regular indications, first degree relative, which is gestational and gestation diabetes. We still have some very discompensated diabetes here. Antibodies, virals, in vitro fertilization. There's a high rate of congenital heart in this population. We don't know exactly why. Nuchal translucencies, TUTR, and ductosinosis detected in the first trimester. Twins and fetal hydrops, of course, abnormal karyotyping and cardiac abnormalities detected and written disturbed. But the abnormal cardiac screening during ultrasound is the most important red flag, and this is what we have been encouraging our screening guys to look at and then refer. So The screening protocol starts in the first trimester from 11 to 13 weeks with the first morphological study, and our markers are mainly nodal translucency, ductus venosus and tricuspid regurgitation, and the second trimester ultrasound. So I believe Dr. President Lula was saying about these two studies, and in this we proposed this 6-level evaluation with no probe rotation coming from abdomen to the arches, as everybody showed, to see from situs, from the abdominal level to the both arch and trachea. And in our guidelines, the color Doppler is mandatory in this, so they can see that the direction of the flow in the arch are the same, and encouraged to look at the size of the vessels, the crescent size of the vessels from IVC to pulmonary artery, and the position posterior to anterior, and very line up vessels. So this is what we encourage the screening, and this is done, of course, by our colleagues, ultrasound and OB and MF, specialists, and of course all the standard fields and imaging protocols are done from by team specialists and the fetal cardiologists, but there are many NFM trained recently with long courses on fetal cardiology, and of course they are able to do all this views and screen, all of them with color. Just to know of note, there is no sonographers in Brazil, so the studies are performed by the doctors. And for morphological evaluation, I'm not going to repeat everything, but of course to identify cytals, cardiac position, veins, morphology, valves, and all the views that were already talked about. And color flow mapping, we encourage to color Doppler in all the structures, IVC, SVC, foramen valley, valves, septum, semilunar valves, ductus venosus, pulmonary veins, great arteries, right and left arteries, and aortic and ductal arches. And regarding the rhythm and Doppler and rhythm assessment, of course, color Doppler all standards views, and PW Doppler for AV valve inflow, E to A waves, Doppler inflow and outflow tracts, of course, ductus venosus, umbilical vein and artery, and ductal arch and isthmus. And the rhythm documentation, especially using M-mode and Doppler or tissue Doppler, as everybody said. So extended protocols are for specific lesions, so we do not encourage everyone to measure every structures. There's no reason to measure everything, but of course, if you are living with a disease, a congenital heart defect, it's better to measure, and you have to measure compared to normal data and according to Z-scores, reagents, chamber pressures, and etc. Regarding timing, so we hardly do any early screening before 14 weeks. It's very unusual. Almost no one trained for that, so few people only, but from 14 to 18 weeks, abnormal screening during the first trimester or previous affected offspring, we can do studies from this gestational age. The optimal window we consider from 18 to 24, but we don't know why. Our regular obstetric practice, they usually order or they refer us for screening for during 26 to 28 weeks. They believe this is the best timing for them in their schedule, but we believe that this is too late. And of course, after that, for serial monitoring of progressive lesions. I think the most important thing here, because everything was said before, is the decision pathway. So once screening is performed and the risk stratification is established, the fetal echo is indicated, and of course all standard views have to be done with Doppler and color Doppler, and then refer to multidisciplinary care. Change this to one. In public care, healthcare, only few centers with the capability to deliver and treat the babies. So the pregnant women are referred to high-risk maternity hospitals, and which are the ones that have NICU, and the babies transferred to cardiac center. And this is the main problem, because we are not well taking care there, and they arrive in bad conditions. And the delivery plan in cardiac center, there are few centers available. So it's hard to have a public center that can deliver the baby and treat the baby in the same time. But for private healthcare, for screening fetal echo, fetal specialist is of choice of the family, and the delivery plan is in a cardiac center or in a maternity hospital. There is a tendency of maternity centers to be prepared to treat congenital heart disease, but there are few cardiac centers prepared to deliver affected babies too. So, regarding scanning and screening, I don't think there's much difference from all was said. And of course, we follow the guidelines from the American Heart Association on the recent one, ACE. And this is the way we conduct here. There are still lots of work to be done. But there are many people being trained, not only not only the cardiology, but the MFM and the institute. So that was what I planned to talk to you, and we can discuss. Thank you for the attention, and sorry that I couldn't share my screening as it should be.
Thank you so much, Simone. It was a beautiful presentation. Sorry for the technical error. Now we're going to invite all panelists to and speakers and to please open your videos. And I'm going to introduce all panelists as much as they can, because we have really tremendous we're very grateful at the Congenital Heart Academy for your time. The first one is Anita Mongridi, and Anita, I think she's the president of the Fetal Heart Society, and also you were involved in the guidelines, right? With Mary. Okay, and then the next comes Ulrika Herberg, and she's from Germany, from Aachen, and she's the head of the unit of pediatric cardiology at the University of Aachen. And then let's see who comes next. Dr. Matsui, we said he's the president of the Japanese Fetal Heart Society, and Dr. D'Onofrio is the ex-president of Fetal Heart Society and also involved in the guidelines. And we have Dr. Laila Tutunji from Jordan, a fetal cardiologist, the University of Jordan. And then we have not Rima Bader, but Lisa Humberger, and she's my ex-mentor and co-author in the first edition of our book and the second edition of the Fetal Cardiology Handbook, and also a head of program in Edmonton in Canada. And we have Tatsu Sarkola. He is a consultant pediatric and fetal cardiologist in Finland, and he's also the head of the fetal cardiology group in the AEPC. We're very honored to have you. And we have the father of this series, the godfather, Dr. Norman Silverman, who's always with us, and you don't have to say a lot about him. Everybody knows Dr. Silverman. And then we have Dr. Sundus from Kuwait. Sundus, can you turn on your video? She's a consultant pediatric and fetal cardiologist from Kuwait. We're trying to involve the leaders from the Gulf area, since we are also working with the Fetal Gulf Heart Group. And I think, Emilio, I don't know you, but you're most welcome. And that's it. So now we're going to open the floor for discussion, and I'd like to get two comments. First, from Anita Mungreti. What do you think of this, of the four presentations, and if you have anything to add?
Thank you, Rima, and thank you for the invitation. It's been a real pleasure the last 10 years or so that I've been involved in these fetal echo guidelines writing groups, to work with all of these people and to see them being used worldwide and translated is really it's really humbling. As far as thoughts, I have so many thoughts. Maybe one that I'll share for the audience is that the indications are something that's debated. I think at every basic fetal meeting that we go to, and it's were even some questions in the question and answer in the chat regarding, is lithium not an indication, for instance? And the answer to that is as complex as Mary D'Onofrio presented with that Vegan's diagram or nomogram of what's your pretest probability, what's your screening situation, resources, abilities, and then what's the justification as far as the post-test probability and what your resources are in your country. So very complex. But even more than that is the data. For instance, I mentioned lithium, that the older recommendations, and by older, I'm talking about 1980s, 1990s, were based on voluntary registry-based reporting. And so those reports were initially very flawed. And so what we've done in the most recent AHA guidelines and in the most recent ASE guidelines is really looked at the most recent population-based literature, given people what the literature says as far as population risk, and then said, it's up to you. This is the population risk. And if your resources can handle it, screen it. Everybody with a 3% risk gets a fetal echo. If your resources can't handle that, then maybe people with a 10% risk. But sort of trying to get away from dictating who should have a fetal echo and really giving people information that is current and correct. And if I could just share something that some people have missed. This was an excellent article from that was headed by this woman from Italy, Dr. De Robertis, looking at international guideline disagreements. And this was actually a very thoughtful presentation. They used PRISMA guidelines and came up with consensus guidelines across the world, which included most of the ones that we've been reviewing. I will just point out that the guidelines from Italy were also included in this survey, as well as those from Japan and the AIUM and ISHUOG that were there. And I just have this last slide, which shows the point, which is that these guidelines, despite being contemporary, were in complete agreement only on suspected congenital heart disease, extracardiac anomalies, and hydrops being absolute indications for fetal echo. And then there was partial agreement for some of the common screening indications that are mostly maternal. And then finally, there was complete disagreement on whether or not resources should be used for assisted reproductive technology, umbilical venous abnormalities, et cetera. And so just shows you that even though we can all agree to get on a webinar, we can't seem to get together and agree on even what the indications are. And I would say that's the first step. And then we can work on agreeing on exactly what images to obtain, what structures to image. So those are sort of my thoughts, that we still have a lot of work to do, but we've come a long way from the days when Mark Sklansky pointed out that two US based guidelines completely disagreed on whether or not to even use Doppler.
Thank you. I mean, this is very philosophical. So we couldn't, I mean, we started with no start, actually, if we don't agree to the indication. So, I mean, what are we doing? I would just also add indications should be divided into two if you'd agree to first trimester and then the 18 to 22, because everybody is talking about indications now for 18-22, right? The first trimester is not part of the indications, I mean, indications of first trimester scan. Is this correct or I'm wrong?
Only partially correct. I think that the most of the guidelines are intended for that second trimester scan, because the first trimester cardiac evaluation is something that's requires a certain amount of technical expertise and certainly equipment that is very expensive, and some countries may not be able to afford this. So again, a resource question. The risk for congenital heart disease is the risk for congenital heart disease. So if you have a 10% risk and you're at 12 weeks, we should look. The heart is completely formed by about 6 weeks. And so the congenital heart disease will be there. So that's why it's a little bit gray. Can you use these so-called indications and translate them to a first trimester setting? Yes, but
With limitations. With
there are
limitations.
limitations. Mm-hmm. Yeah.
Okay, great. The next one, I'll have also Dr. Lisa Hornberger. Can you comment on what been said so far? I know you have also philosophical ideas about screening and indications and so on.
Yeah, I mean, I agree with essentially everything that Anita is saying. I think that some of the reason for picking and choosing indications, again, may get back to what's available from a research perspective. And so from different countries, you say, oh, why are we doing these screens? If the risk is this low, we should really only be identifying ones that are this, and getting away from trying to be completely uniform on exactly the indications until we have better clarity around things like lithium, where it's maybe dose dependent, and really those should be the higher risk ones should be sent versus those that are on lower doses or whatever. But I think the idea of getting to kind of relative risks and really where our cut zones are, cut points are for a given jurisdiction based on health resources. An example for us was we don't screen every diabetic because we know that the risks are low for many. And we did a big population study with our own population in Alberta and showed, this linear increase with increasing hemoglobin A1C, which others have shown, but chose to pick a cut point of 7% versus, all the way down here. And then know that if the mom is an older mom or it's a multiple pregnancy, that risk actually increases. It brings the whole risk up. And so we're slowly kind of better fine tuning even for our own jurisdiction, where we make those cut points as to indications. The one side about screening, guys, and most of us are really pretty aware of this. We will not make as many diagnoses as we know we can until we can continue to improve prenatal screening internationally. I mean, that's just a fact. That is a big part of what we all need to be doing. So Mark's presentation was really quite important. That has to be exactly what we are really pushing alongside of optimizing. It doesn't help us to sit in our ivory towers and do these beautiful images and get every single last detail when we don't make those diagnoses. And you're looking at the scarce, very little data out there internationally, places all over where there are low and middle income countries, and they're making diagnoses at 10%, at the best 30%. And so places that we can actually do far more work to make sure that there is adequate detection and bring more of the populations up to speed. So
Well,
that's a big one.
I like what you said, but I just wanted to ask you as well, and you said a very important thing. Diabetes is not part of and also Mary D'Onofrio said we're taking it out. Did I get this up? Gestational
No.
diabetes or something like that? Oh,
Gestational, yeah, but not first trimester or pre-gestational diabetes is still an indication.
so we've taken gestational, and Lisa's saying, are you saying you cut off his hemoglobin A1C of 7 to scan a diabetic? Is it gestational or primary diabetes? Which one is that?
Gestationals in our population, we looked at over 500,000 pregnancies. Gestational diabetes had exactly the same risk. And it's because we have a centralized program and we can identify all the pathologies pre and postnatally. But gestational diabetes was exactly the same risk. And others have shown that. We're not the first to do that. But when we looked at the pre-gestational, there was definitely this sort of linear increase. And we said, okay, where's a cut point that we can accept, a risk of congenital heart disease? And these are major heart defects. These are not everything because the literature is full of stuff that relates to postnatal diagnoses, relates to screening postnatal diagnoses, and they pick up ASCs that end up closing spontaneously. What we want to know is what we can detect and say, okay, what cut point, what risk are we willing to say we need to see all of those for that given risk? And I think that relates to what your jurisdiction's resources are like, what you can handle.
Yeah,
You don't want to be scanning everyone.
but you know that hemoglobin A1C is not is not really directly related to the chance of congenital heart disease, right? We all know that. So the higher the hemoglobin A1C does not mean that this baby is going to have congenital heart disease, and the lower one does not exclude it. So I'm not sure. I'm totally with you. In Saudi, we have a very high rate of diabetics, and I've been scanning gestational diabetics. And the MFMs were saying, well, what guidelines are you following? So I wanted to add, Mary, you've taken the gestational out of the indications?
Yeah, we did, but I think you're missing the point, Rima. I mean, what everybody has kind of said is you have to use your local data, right? And ultimately, for example, what the pretest probability means is that if we could detect 100% of congenital heart disease on the screening exam, there would be no indication other than somebody saw something was wrong. So that's really what we need to shoot for is that screening exam that can identify important congenital heart disease. And when we get there as a community, then the indications go away. So until then, what we're left with is this very artificial cut point that has to take into account what are your resources, how good are your screeners, and then set that depending on that. So I don't think any of us can comment to the Saudi group as to what hemoglobin A1C to use. The IVF thing, for an example, we struggled with, but the point is, at least in the United States, if you're having IVF, so many people look at that baby that probably the risk is lower than the population risk because they get so many scans from a high level provider. And so that's kind of how we have to think about it is if your screener can identify congenital heart disease, they don't even have to name it. They just have to identify an abnormality. Then a lot of these risks are just going to fall away. And that's going to completely depend on your region. And that's the problem with using guidelines. And why every single guideline has a little asterisk saying, depending on local resources and what your accepted risk is.
And Lisa's in Canada and you're in America, and you're not agreeing on the indications. Now, also, in the insurance companies here in Saudi will follow the guidelines, so they're not paying for diabetic. I think it's unfair. Yes, yes, Mark. I'm sorry.
Thank you. Yeah, I just wanted to 100% agree with what Mary and Anita have been saying, that it's so, the reason to do a fetal echo is so dependent upon, it's because you think you might be missing something at the screen. I mean, if you're not missing, so it's so dependent on community. We at Cedars, we're just talking about our IVFs. Are we missing any IVFs? If we're not, then maybe we don't need to refer. And that's what everyone should be doing. If the screening in your community is picking up all major heart defects, then it means fetal echo as a screening tool is less important. So I just want to, I can't say it any better than Mary did. I agree 100%. It's so dependent upon local the capability of the screener, and then how much added benefit is there for those who do a fetal echo beyond the screeners.
Can we go to Dr. Hikaru in Japan? How is it, the screening and the payment for the insurance for the scan to be done there?
Yeah, in Japan, there is no insurance for the cardiac screening, for the obstetrician and sonographers, and just the voluntarily the obstetrician checks the heart.
Okay.
And
So the system that 18, 21 weeks, the obstetrician will check the heart and then and this is paid already and not paid by the insurance. If the obstetrician is the one who's doing the scan, paid by insurance or not?
yeah, there is no insurance for the checking the general the body
Oh, okay.
weight and the measuring, and also the checking the general organ abnormal
Abnormalities.
checking
Okay,
point.
great.
Yeah.
Great. And we go now to Germany, Ulrika. The system in Germany now in Europe, and we'll talk later on.
Yes, I can't talk about Europe because it's better than
No,
Germany,
Germany.
unfortunately.
Well,
Yeah,
it is in Germany. We'll talk to somebody else.
yeah. So in Germany, we have the system that a screening is done by obstetricians, and there's also a general screening done paid by the insurance, done by obstetricians, and they do a general screening including the four-chamber view, the position of the heart, if there's arrhythmia, and the size of the heart. But they don't include outflow tracts or three-vessel views. So we have a low detection rate by screening, and this is really poor. We are one of the countries in Europe which has the lowest screening detection rate, and we are very, let's say, as a pediatric cardiologist, I'm very unhappy. Although, if a defect has been detected and the patient comes to a further, let's say, somebody who has more of knowledge, then the diagnosis is very well done. We have really famous perinatologists. So at least I have to tell you that in Germany it's paid, but the detection rate is low because we use only the four-chamber view, and we want to widen the screening to add three vessel view and outflow tracts, but then the policy is very difficult. So it's very difficult to change political things. And we now, on the 5th of May, is also a big meeting. We try to change this to get better. In Netherlands included in the screening, three vessel view, outflow tracts, it has a much higher screening, a better screening results than we have. It's just 1 kilometer from my place, Netherlands. So it's just around. I can see Netherlands from my window.
But still, no, but let's say, so the indications are picked up by the obstetricians and MFM, right? And if they find anything, they refer them to the fetal cardiologist, correct?
There's no indication. Everybody gets a four-chamber view. Everybody gets a four-chamber
view. As screening at 18 weeks?
No, at 20, let's say 17 to 20 weeks.
Okay, all right. Okay, but let's be fair to Germany. Rabeh Shawi is from Germany, so he's the one who made the four vessel view, whatever. I know since I was in training that this field is controlled by MFMs mainly, and pediatric and fetal cardiologists are not well utilized so far. I thought things have changed, but
no, I think my clue is that we need a good screening. This is the first step. We have in the low risk population, we have to find those who have critical heart disease, and therefore the screening has to be without indications. The screening has to be in everybody, and we pay for screening, or we get paid, or my system pays for screening, but the screening results are poor, and that's not acceptable in my opinion.
Okay, I understand. Thank you so much. Dr. Sarkola, you are from Finland, and you're also heading the APC Fetal Cardiology Group. So tell us about what is the practice in Finland and probably a little wider into Europe.
Thank you very much. It's an honor to be participating in this session. I think in many European countries, maybe in Germany some problems, but in many European countries, the population-based universal screening is governmentally funded and very comprehensive in the obstetric side. So it's really optimal if during the past years with training of the screening sonographers, we've been able to improve detection beyond 50-60% of major CHD in many European countries. So I think the point they are making, the previous speakers, is really good, is that we should focus on the screening part and then think about the referral processes, how to improve that to lower the false positive screening results and to improve the workflow in the detection of CHD. I don't think we will ever get to 100%, so we always need to remember that the neonatal phase screening must be in place. So we always will depend on that.
Thank you, but I just wanted to understand how does the referral channel go in Finland? So I was just heard in Germany, it's the obstetrician maternal fetal medicine, and if needed, they go to the pediatric cardiologist. How is the system? Who are the first liners in Finland?
So in Finland, it's basically the midwives who are the sonographers doing the screening. And then there is a perinatologist who checks it prior to referral to a fetal cardiologist. So that's really the way it goes. And for the ones that are in remote areas, we also do it by telemedicine and look through Teams on different images. But I think the perinatologists are really the key in that process because they are the ones who are so, in a way, regulating what the sonographers pick up and which ones should be referred to the fetal cardiologist.
And it's all paid by government, right?
Exactly, yes.
Beautiful. It's very, very good.
Yes.
Actually ideal. And your detection rate is improving, you said.
Yes. I think we're in the Nordic countries that I represent, we're up to about 60% of major CHD detection now.
Any idea about UK?
I think there can be regional differences there, but they're probably at least at the same level.
Yeah, it's paid by the government, I guess. It's all NIA. Okay.
Yeah.
Great. I'll leave the floor for we have a question from the audience saying about the lithium. That the question goes to the panelists and the moderate and the speakers. Why is lithium out of the indications? Mary, please, at least Mary, and then we get the rest of the.
I mean, I feel like Anita answered that. And so we can repeat it, but the data where it was indicated is old. And the newer data suggests that the risk is not higher when you take the pretest probability into account. We thought long and hard about it, and that's the current data, current modern data, or the current modern best data. Anita, I think you said it perfectly.
I think more interesting might be some of the other teratogens like retinoic acid and warfarin. What we were saying, we weren't saying that they can't cause congenital heart disease at all. Exposure to these drugs causes a lot of anomalies. The point was that if those teratogens didn't cause a major anomaly that was easily detectable by the screening ultrasound, and by that I mean extracardiac anomalies, that it was unlikely to affect the heart in isolation. And so the just getting a history of warfarin exposure doesn't automatically get you a fetal echo. If you have a normal screen, then your pretest probability is low. So it's a subtlety that I would suggest. We spent a lot of time on the wording there in these documents to try to be clear that that we are not saying that these teratogens are not teratogens. We're saying that they're unlikely to affect the heart in isolation, and therefore the indication for fetal echo becomes extracardiac anomaly in the setting of teratogen exposure.
Yeah, absolutely. And I saw the same thing for like advanced maternal age. So, with in the absence of a genetic abnormality, advanced maternal age, an absence of a genetic abnormality and extracardiac findings in isolation, the pretest probability does not put it into the category for a fetal echo. But they should have a cardiac screen, absolutely.
Yeah,
And if they have some, and if they fail the screen, then they get a fetal echo.
yeah. But do people use lithium anymore? I mean, this is 30 years
Yes.
old. Is it in specific cases? I mean, I haven't seen for 15 years now patients on lithium in my practice. But is it that it's not uncommon, right?
No, we see it.
You see it, okay. I have seen something when I was in training with Dr. Huta. There was a rat model that they fed baby with the rat with lithium, and he got Epstein. I've seen it myself, so I don't know what this means to the panel.
It means if you give rats lithium, they get Epstein's.
Yeah,
And it's
so
also, there is data to suggest there's a dose related effect. So, there's a lot of nuanced stuff in here,
Yeah.
and it's a question again on what your thresholds are for whether that risk is enough to do a screen. Well,
But
all of them need screens, as has already been said. They all need good screens, but whether you decide to take higher risk pregnancies, depending on your screening, how well your screens do, whether you take certain exposures and include those in your fetal echo practice as indications.
let me explain it a different way. Is if your patient is on lithium and the four chamber is normal, including
okay.
looking at it in real time, what do you think the chances are that that baby has Epstein's that a cardiologist is going to detect? If your four chamber is normal, especially if people start adding color, which is being recommended, normal right atrial size, normal right ventricular size, normal cardiothoracic ratio, normal axis. What are the chances, and normal crux of the heart? These are things that are supposed to be looked at for chamber screening. What are the chances that that has Epstein's? Probably close enough to zero to not justify sending every woman who's on lithium to a fetal echocardiographer.
I think this is very safe comment, Anita. I would also add color if there's no tricuspid regurgitation, if you missed that. Thank you. I'd like to go to Mark. Mark, you said, I'd like the future guidelines to have extra things that you've mentioned. Could you please elaborate on that?
Just to go over it again, or
No,
I
no,
mean,
you said,
put it this way. But I mean, I think and I'm sure we're all in agreement that many forms of major congenital heart disease, the children do better when we know about the diagnosis early on. So there's a benefit for early diagnosis, and we know that we're missing, globally speaking, a large percentage of major forms of heart disease that would benefit from prenatal detection. So we know we're not doing a good enough job. We need to do better. And I think there's all of us on the call probably recognize that certain things that we can add to the screens, since it's so critical. I mean, believe me, I'm very reluctant to add to their job, because the people who do the screening are already seeing a lot of patients in a day, way more than I do as a pediatric cardiologist. They're looking at a lot of patients. They're looking at everything, not just the heart. Babies do not cooperate typically. The spine's up and stuff. So I get it. So I'm reluctant to have to add more, but I think we do need to have a higher bar, and to ask more of those who screen the fetal heart, because it's so important to do better than we're doing. And so I think some of the ways to do it, we've been, Marion, Anita, and others have mentioned, I mean, the importance of color, the importance of clips if they're not being recommended already, the importance of optimizing the angle, optimizing the image, even paying checking is the ventricle squeezing or not is actually not part of those guidelines I mentioned. So I think we need to do better, and there's going to be differences of opinion what's the first step. I agree. I think that Mary mentioned maybe color. If you're not using color, we should probably be using color for a routine, and that doesn't just happen. You need to learn how to do it. But I think so. I'm interested in what other people feel, but I think we're all in agreement. We need to be better at screening. If we're really good at screening, then it's sort of obvious. The only indication is, just as Mary was saying, the only indication would be an abnormal screen, and we wouldn't have to worry about these other indications.
One important thing you've added: proper pressure while screening, while doing the echo. You wanted to do, and you have a special thing that you press. Okay, I asked you one question, ask the others. Do you agree on 1, 2, 3 that gestational diabetes is out of the guidelines? IVF is out of the guidelines, and I forgot what was the third one. It's out. They updated taken or more.
I think it was single umbilical artery was one. But again, I think to leave with that message is incorrect. I mean, basically,
we're not leaving. We're not leaving now.
If their screening test is normal and you happen to have gestational diabetes, you probably shouldn't get a fetal echo.
Okay, I got you. So screening is a baseline that everybody has to have proper screening. If you have in your setup proper screening. Now let me go to Simona. Simona in Brazil, and this is very important what Lisa Humberger said, that depends on what you have in your society. If this diabetes is high, like in Saudi, you have to adjust that or whatever. What adjustments have you done so far in Brazil in your practice for about 15, 20 years? And you think the guidelines should attract this for different ethnic groups and different areas?
I believe that if we brought the indication, we have more people addressed and with the chance of the diagnosis. And I think, of course, screening is the key of everything. It has to be started early in gestation, in the first trimester with the markers to appear the red flag, and then 18 weeks. But I think if you have a diabetic mom, and because she was diagnosed during gestation, and you don't look with the same eyes, if you have in mind that, oh, this is an indication for fetal echo. So I think when you brought in low in countries that the screening rate is low, to have more people having the heart assessed. That's why we still keep IVF, we still keep, of course, IVF, lots of studies are performed, but it's the opportunity to someone that was trained to look at the heart, to look at this section. So here, regarding the insurance companies, there is no limit. So if you want to do that, or if you want to take OBS orders, a fetal echo, it's done. So many of the fetal cardiologists here think that a fetal echo should be done in all pregnant women. I don't agree with that. I agree that we have to train for screening, as everybody told, as everybody said already. So screening is mandatory. And these people who screen the heart, they have to understand the normal heart and what you shouldn't see and what you should see. But if we extend and broad indication, we have more people directed to people trained to look at the heart. So,
government pays for that, the insurance pays for the screening and for echo?
yeah, they pay. They pay.
Oh, that's very good.
The screening for the echo, and you know what? They don't. They pay as many as necessary. As many as necessary. So what I see here, people see like 3 or 4 specialists because I want to listen to her, to him, or to the other one. So it's not organized. and many people don't have access to one single study, you know? So I
Yeah.
think so here in Brazil, it's better to have a broad indication, and people remember that they have to look carefully to the heart when they are screening. Otherwise, it's just one more, and the major defects are missed.
Thank you.
That's what
I'd like to ask Dr. Sundus from Kuwait. You're also a fetal cardiologist in Kuwait and the Gulf. The government pays for the screening or the fetal echo?
Yeah, definitely. It's available and for free for everybody, and the government will take care of it, actually. We start the screening with the obstetricians and sonographers. If you go through protocol, then they should refer to MFMs, and then if anything detected abnormality in the anomaly scan, then they will refer to fetal cardiology for final diagnosis and plan for the postnatally. But sometimes the sonographers will just, or obstetricians will just bypass the MFMs and will refer the patient directly to our side. And then that's why where there is overwork and overload on us, because most of the time the referrals are unnecessary, as you mentioned in the protocols and guidelines.
Okay, great. And we have Dr. Laila Tatunji from Jordan. So the government, what is the system there? And does the government cover this screening and the echo in pregnancy?
Yes. Hello, everyone. Hello, Dr. Rima, and thank you for the wonderful panel for their overview. I want to say in Jordan, we are a low middle income country. And we have the government, 1/3 is insured through the army system, which is like the VA system. And then we have 1/3 of the population that are uninsured, but then half of them have private insurance. So this is how the situation is in Jordan. So at least 2/3 are insured either by the Ministry of Health, the government, or the like the military, kind of similar to the VA system. I would like to also say that we have about double the global incidence of congenital heart disease. Like the global incidence is about 8 per 1,000 live births. In Jordan, it's about 14 to 15, almost double. And these incidences have been echoed in some of the countries around us, like Lebanon, report a similar incidence, and also Turkey and Iran. We don't know why. We think perhaps it's related to consanguinity, or maybe because we don't have folic acid fortification of the wheat. We still don't know, but it is work for us to explore. Our system provides a fetal obstetric specialist, and our fetal specialists are really good. They do 4-chamber outflow, color Doppler, rhythm assessment, and if there's any abnormality, they refer to the fetal cardiologist, and also other indications like usually I do get diabetics because the obstetrician detects biventricular hypertrophy. And then, they're concerned because, is this some kind of a myopathy, hypertrophic, or is this just related to glycogen from
Glycogen storage, yeah.
gestational diabetes, or is it a valvular obstruction? So they refer. When they see the hypertrophy, they do refer. I want to say thank you for the guidelines. Thank you, really, Dr. Donforio and Dr. Slansky and Dr. Rima. When I returned home, I trained in the US and returned home. And then suddenly, I didn't practice in the US. So suddenly, from my mentors to being the consultant and the main specialist that, gets a lot of the referrals. So I relied on the guidelines that were published. I followed the publications, I followed views, I followed Dr. Rima's recommendation and Dr. Lisa.
Well, Laila, you've been cut off very good, but I understand
Thank you.
that
So
you
I would
appreciate
say
the guidelines. Yeah. Because time is getting.
I want to say that education. Yeah, I just want to say that education and having free access to the guidelines can tackle disparities in developing and low middle income countries. Because if you have the machine, which you can have, the way to apply it, when you have free available resources and guidelines, it kind of decreases the disparities, and we can have better detection in low middle income countries. But I just want to end on one thing. We really need guidelines for the future on hydrops and things like twin transfusion and evidence-based, perhaps to be added to the usual guidelines that we have, so that we can improve the outcome also globally. And thank you so much.
Beautiful that we feedback from many. And Anita, there is now we go for the expert in AI now. There is a lady, or Dr. Annika von Niekerk. She's saying that we have very few ops doing scans as community, and trying to teach midwives to do basic growth. An AI for fetal heart scan, you think this will improve? And how far are we with developing a model in AI for basic fetal heart scan?
So I only heard part of your question, Rima, but I think I know I know what you're getting at, and I did put this in the chat. A lot of the screening that we're talking about is actually not being done by specialists. It's being done by midwives, and most of the vast majority of children with congenital heart disease are not born in Europe, and so their prenatal screening is excellent, but we really need to get this expertise into the hands of midwives and really untrained individuals if we're going to democratize this type of healthcare. So, to answer your question, I personally think that AI, which can easily do image recognition, they use it for detecting cancer and other lung anomalies on chest x-rays, and histology. You can even use AI to tell whether a spot on your skin is cancer or not. So certainly we've trained models to recognize the four-chamber view, to recognize the three-vessel trachea view, and to recognize whether or not they are normal. And I think that we're almost there, fine-tuning these models so that when a model says all of the views are there and they are all normal, that you can count on that you do not need to refer that patient. The problem is that even with 98% certainty, you still are talking about a 2% of the global population of pregnant people that would have to go on for more testing. And so we've got to make that a little bit better. But when you ask, are we there yet? We're not there yet, but we are very close. I think that that AI at the point of care, being able to identify normals and being able to triage out the potential abnormals is going to be the way to go.
But you have done a paper, and you've done quite a number of ladies. How was the result? It was very good, actually. If I recall. So you still need to. The detection rate was quite good, right?
The detection rate is very good. The problem is the false positives. So we need to be able to count these. The models can pick out abnormal better than humans. We've shown that multiple times. But we need the model to be able to say it's normal. and to be able to be used at the screening level, or it's not just not helpful.
So how high was the false positives in your study?
Well, there's been a meta-analysis of all of the AI studies done, and the best that people can do is about 98% specificity, which translates to to millions of false positives. So we still need to do some work on that.
Thank you so much. I'm sure we will. Now, I also just to end our beautiful webinar, I'd like to get you what messages would you like each of you, Anita, Mary, Lisa, Mark, and others? What messages would you like to send to the audience regarding? You're all been practicing for quite some time. You're all well known. You start, Anita? You want to start?
My message would be that we've come a long ways working together, and we should continue to do so. And that our overall goal should be that all pregnant people should get the same, level of diagnostic excellence in order to improve congenital heart disease recognition and treatment worldwide. And I just want to put in a plug for the ISHWAG Every Little Heart Matters campaign that's ongoing. If you go to the ISHWAG website and just look for Every Little Heart Matters, there are a lot of educational resources and other information there that's trying to not just improve things in Finland and Germany and the United States and Canada, but really all over the world. So that would be my message. Keep working together. Use the resources that are available, and have a goal in mind of improving the prenatal diagnosis for everyone, not just particular regions and not just the IVF patients.
And prenatal diagnosis will save money, a lot of money for health crisis. Mary, I would like to hear what you'd like to say.
I think, I mean, my take-home message is what we've been saying all along and what Anita said. I think we need to work together as an international community and concentrate on screening. And this involves collaboration with our colleagues who are doing the screening. So we're the experts in imaging the heart, but how can we work together with the screeners to improve detection? As far as the fetal echo guidelines that we wrote, Anita was the lead author. It truly was a labor of love. It was really to say, can we put things down on paper that really will help people who are scanning the fetal heart to really know, what to look for. And I really just want to just say thank you to Layla for just her fabulous comment. I mean, it was so heartwarming to hear that somehow our work is reaching globally, even if you print out that article and put it in your pocket. Know that I'll put in a plug for the Fetal Heart Society. Know that the Fetal Heart Society is an international organization meant to really bring people together, senior people with junior people. It's a research organization, but certainly we're here to educate and mentor. So feel free to check us out. And that's what I have to say. Thank you, Rima.
I just want to say, of course, the guidelines are so important. And the idea is that we should use them. But the question was that, and what are the difficulties? And from this discussion, you find that how much you do of that. Of course, data updates and for any and everybody. I mean, the differences makes us come together more and more. Lisa, what do you want to say before we end? And then we have Marcus.
I agree with Anita, Mary. So, number one, we've got to improve prenatal screening internationally. That's key. And making sure, pregnant women are able to get to people that can screen effectively. We need to optimize our access to the expertise, and then our routes to getting those patients ultimately delivered in the right place, in addition to making sure that they have the options available in their jurisdiction. That's key to all of this. It's not just fetal echo, but it's the whole picture. Anyways, thank you so much for having me.
I'd like to make it clear from what I understood from what you said. Also, think of what you have in your place, in your country, in your society, and focus on that. Use the guidelines as can concentrate more. If you have congenital heart disease, or as we have in Saudi, also you have 50 than 8. If you have diabetes, if you have like sort of many referrals with the guidelines, but think of the local need. Do you agree to that?
Yeah, you have to work within your infrastructure and resources, but also advocate. There are
The guidelines.
many places that you could potentially be advocating for better resources and for the needs of your program and your jurisdiction.
And thank you. Mark, do you want to add anything before we close? 7 o'clock.
Thank you, Rima. Just to thank everyone. I agree with everything that people are saying in terms of the importance of screening around the world and to improve prenatal detection for everyone around the world. And the fact is, it can be done. I mean, there's many areas around the world that have instituted programs in their communities and have had demonstrated significant improvements. And so I think it's possible. It's not just a pie in the sky. It actually can be done, but it does take, like Anita had mentioned, a multidisciplinary approach, working us as fetal cardiac imaging specialists with those who do the screening. But it can be done. So it's exciting to work with all of you, and I appreciate being part of this group.
Thank you. Dr. Sarkola, do you have anything to add?
Thank you very much. I agree with what everybody else is saying. I think it's just getting healthcare and the screening for everybody as a universal screening process, and then optimizing that. We have the knowledge how to do it. It's just the implementation that is needed here.
And collaboration, working
Yes.
together.
Yes.
Okay.
Yes,
I think
absolutely.
Dr. Matsui, do you have anything to add?
I also completely agree with everyone that the collaboration and that we also want to discuss that furthermore about the screening and also the fetal diagnosis all over the world.
Thank you. I also think collaboration between high income, middle income, low income countries will improve the detection rate and
Yeah.
the registry worldwide, because in certain areas we have certain diseases more than the others.
Yeah. I also want to know that the ethnic or something the area that we are Asian and also the Western people there's some different about the indication of the screen. I want to
This
know.
is very important. Yes,
Yeah.
yes. Thank you. Ulrika, do you want to add anything?
Yes, first of all, I think a registry would be very fine, and it is important to know exact numbers. But secondly, to the second point, we also need maybe a country-dependent individual plan what we do if we have if a fetal heart disease has been diagnosed. So a plan where to deliver, when to deliver, and this has to be done maybe individual in every country. But this is the next step to improve after diagnosis of congenital heart disease in the fetus, to improve outcomes. And that's the next step which has to be done.
One of the missions, correct me, Mary, of the Global Fetal Heart Society, they are trying to reach out. Mary, do you think this is where a Global Heart Committee and the Fetal Heart Society is trying to collaboration outside North America? Is this correct?
Yeah, I mean, the Global Hair Affairs Committee is in development right now, and the board of directors is trying to figure out how to help the co-directors, which is me and Dr. Macias, kind of organize it. But the general point is the same mission as the Fetal Heart Society in general, which is to bring together international multidisciplinary collaborators. So anybody, who wants to learn and who wants to interface with the rest of us is welcome. And we have, certainly lots to offer, and we welcome, opinions and thoughts from everywhere, because I think that's so important.
I think it's a beautiful mission, the Global Committee in Fetal Heart Society. I would like to ask you, Mary, do you have a fetal registry worldwide where cases could be included, and then research would come out of that? I think it's a beautiful
Yeah,
thing.
I mean, I think first off, we're running out of time, so I'm going to have to say goodbye. But I think our current Fetal Heart Society president, Anita, has been instrumental in trying to get us involved in kind of the registries that are happening through Cardiac United, pulling together multiple databases. We have a long way to go on that. But it certainly is a mission of ours to have fetal databases and fetal registries. And I think we're just in the beginnings of that.
Must say, in the Fetal Gulf Heart group, we're very happy to share our data with, if you have a registry that includes other countries. And I think the Middle East is very rich in congenital heart disease. Anita, do you plan to do registries? And is there a way for collaboration for different countries to put their input for fetal hearts?
Uh, Well, I would love to have a worldwide registry, of course, of congenital heart disease and outcomes. This is not going to be,
Fetal life.
yeah,
Fetal life.
no, in fetal life, this is not going to be economically feasible, I think. But what we can do is piece together other efforts and try to get the registries to the individual country registries to work together. So I think that is another plug for using artificial intelligence and using all of the tools that we have available to scale this type of effort. This cannot rest on individuals or even on individual societies. Um, and so I would again point to the ISHWAG efforts of the Every Little Heart Matters, and to the Fetal Heart Society Global Affairs Committee that Mary mentioned, and say we should keep up. I don't know. I don't see a worldwide registry of fetal heart disease in my lifetime, but we keep working on it, and maybe that's an ultimate goal for the next generation.
Thank you. Thank you so much. I'd like to thank all of you, eminent speakers and panelists. And I'd like to say this is a recorded webinar. You can also watch it on the YouTube within the next 24 to 48 hours. I've learned quite a lot, and thank you for your time. And good night or good day.
Thank you.
Thank
Thank you
you.
so much.
Bye-bye.